Psychological and biological factors in mental disorders. Our speaker, Professor Erik Wong, although he is now teaching in the University of British Columbia, has studied and worked in the UK for 16 years. He is a gifted man who is both an experienced and professional scientist, as well as a humble and caring mentor. It is one of my biggest fortunes to have known him. So please let us welcome Professor Erik Wong.
Thank you very much, Rice. Really appreciate the invitation from yourself and also from the Cortex Club. I chose today's topic because there's a lot of needs in science in the clinical world, of which mental health in general remains a challenge. And I put a slightly cheeky title, and hopefully it becomes, will reveal itself as we proceed. Well, if I can just move, okay, first slide. The framework of my talk is really split into 3 different sections. I'll try to take about 40 to 45 minutes to cover 40 slides, and then leaving about 10 to 15 minutes for questions. I apologize that I cannot be there in person to answer your questions. One of these days, next time I visit UK, perhaps I can come for a visit. But this is a very passionate topic of mine because I've been in industry doing psychiatric research for 33 years, and mental disorder has been a very, very important source of scientific challenge for me to tackle. So the talk in the next 40 slides, it will be in 3 sections. I'll first outline when we say that mental health is a real problem. What exactly is the magnitude? What are the problems and why we need to address it? And so is the mental health burden. I will bring you up to date. Where have we come from in terms of when we talk about mental disorder, and particularly for today's discussion, I'm focusing on depressive and depressive disorders in general. And there are a big history of the conventional treatments and the remaining challenge. Then they will move to much more the frontier work in biological psychiatry in terms of what do we have in terms of new targets and new therapies. Do we remain focused on the brain, or in fact, do the scientific information draw us to other areas? And I want to bring you up to date to that. And one point throughout the whole talk, and it's a bit of a scientific pet peeve of mine, is I'm truly believe in the idea of translational neuroscience, in the sense that we spend a lot of time, scientists doing modeling using animal tissue culture, etc. But also, are they translatable to human? That's got to be a question that asked every time, every day when we do our work. And what can we learn when we're doing human measurements that can then feed back into the way we model, the way we adjust, and the question we ask? Because all of these practices allow to practice to fulfill our mission in psychiatric drugs discovery, of which I will summarize towards the end. When we talk about burden, I mean, we all either individually or know somebody in the family or friends who have had challenge. And issue about it is, unlike cardiovascular, unlike metabolic and other disorder, which is not that anybody needs to be proud of, but on the other hand, you don't need to be shy away from it. But psychiatric disorder has a certain social stigma attached to it. In fact, in certain culture, like the Japanese culture, they would not even announce a diagnosis with psychiatric. Anxiety disorder will be considered as a cardiovascular condition, even though they prescribe benzodiazepine for it. That is a sign of the stigma. But when we talk about the modern health, mental health disorder, the magnitude is the following. There are 3 slides to show it. It's on the rise in every country across all ethnicity, all genders, all cultures. And in fact, the estimation from this Lancet commissions in 2018. First time they did a really deep dive into this topic. They come out that the cost to the global economy can be up to 16 trillion. That's 10 to the power of 12 zeros, between 2010 and 2030. And if a collective failure to respond is not addressed, and I will touch on when we say respond, how do we respond to it? Is it purely research? Is it purely clinical practice? What other elements are involved? When we talk about, there are multiple ways to show what is a mental health burden. One way is to use the public health term called DALYs, which is disability adjusted life year. It's a bit like an area under the curve calculation of if you have this given disease, how much time it will cut into your effectiveness in life. It's not about death, but it's about disability. And in the sense that mental disorder as well as substance disorder are suggested by the blue bars, which indicate that the age range of which they are most disabling, and area under curve give you the quantitative amount. Comparing to self-harm, which is a different way of talking about suicide. Depression and its consequence remain one of the bane of our modern society, regardless of culture and regardless of socio-economic class. So none of us are immune to it. And the question is, why is that the case and what can we do about it? Is it always wait till the disease to occur and then we seek to treat it? Or can we think about neurodevelopmental issues? Or can we think about preventative issues? That's the basis of some of the discussion. And in terms of real number, around 1 in 4 people will experience some form of mental health problem. And we don't need to look around. I mean, when we feel stress, whether it's mild or moderate or severe cases, it is our biology, and it's nothing to be shy of. But knowing about the biology, having the passion to want to do something about is the basis of why we're actively doing research in translational neuroscience. Such that in the World Health Organization say that 1 in 4 will have experience some mental health problem in the course of their life, and account to 15% of the cause of disease in the world. And in terms of absolute number, WHO showed that the prevalence in millions are something like depression is 300 million, dementia is 50 million, schizophrenia and 23, bipolar 60. In terms of schizophrenia, you might not know that if you look in the prison population, 60% of all antipsychotic being used in a given Western society, whether it's UK or the US, is by the prison population. There's an overrepresentation of psychosis and schizophrenia in our patient population. There are no other health condition in humankind has been neglected as much as mental health. And that is from the co-author of Vikram Patel. He was at the London School of Hygiene and Tropical Medicine before he went to Harvard. So the challenge is, in a biological way, how do we monitor, diagnose, treat, and what kind of policy should us and our government adopt? One last point from this very thick but important paper by Patel et al. At 2018 is, given this challenge, the scale and the scope, what is the recommendation? And there are a number of recommendations, and are you happy to know that I would not plow through all of them in this short period, except to zoom in on the 3 principles to reframe mental health. In particularly, I'll draw you to the one that's underlined. That is important principle to think about going forward, is to reconciling the nature versus nurture debates. It's a much more a biological consideration about how to reframe when we think about mental health. And that is converging on social and biological determinants. That is the key word. biological determined. And sometimes, in fact, when you design experiment, can you incorporate not only the biology, but the social context in the animal models? And we'll give you an example of that. A mental health problem, and treat it as a life course of a trajectory of neurodevelopmental process. Because sometimes when we look at do experiment, unless we do a longitudinal study, it's a time lapse, it's a glimpse, it's a shot, photo shot in time. But in fact, understand the time course could be the way to help us to understand what exactly the mechanism, how does it play a role in disorders. Lastly, in terms of the burden of mental health, what about how our society been treating it? In the United States, even recognizing on the left-hand column, mental health impinge on the most number of years of disability for individuals who suffer from it, and in turn, society. When these people are disabled, they cannot work, they do not contribute, and in a lot of cases, they disrupt social standings and disorder. It has the number one, followed by metabolic, like obesity and diabetes, and neurological. And in terms of years of death, cardiovascular, I mean, if you have severe cardiovascular disorder, heart attacks, coronary, you die. So they are different in terms of year of disability versus year of death. However, in terms of research spending, mental health continue to be very low in the totem pole. Unlike cancer, which although have moderate years of inducing death, yet by virtue a number of government sponsorship and emphasis has been involving. So we need to think about how to address that discrepancy, that mental health will take a fair crack in terms of research funding to address. And hopefully at the end of the talk, you have an idea of some of the substrate we should think about that to spend the money and the research funding. When we come to addressing the treatment of mental disorder, of course, the four sections that we think about is, engagement in psychology, counseling, social work, psychiatry, and as well as family support. But of course, those are all front line in front, facing the society. But the forces behind to progress in the treatment options would be research. And I'm talking to a set of researchers who are going to be the future of our world's problem solver. I'm focused for the rest of the slide, primarily focused on depressive disorder in particular. Different disease will have different modeling requirement, different deficit. But for the case of major depressive disorder, which is what the GP or the doctor diagnose, consists of typically 9 to 10. The range of symptoms, including depressive symptoms like loss of pleasure, anhedonia, feeling helpless and low, and then cognitive deficits, sleep disturbances, anxiety, fatigue, sickness behavior, HPA dysfunction, somatic symptom pain, and poor functioning in general. And the diagnosis of major depressive disorder is that 5 out of these 9 criteria have to be reported continuously for 2 weeks. And of which out of the 5, 1 of them has to be either loss of pleasure or feeling helpless. That's the clinical definition of depression. And as a disease, unlike cardiovascular, bacterial infection, this is a very complex polygenic disorder, and it is up to this point measured purely assessed by symptoms on rating scale, on checking boxes. And when we think about treatment, you hardly ever is really about, we don't even know whether this is one disease or multiple disorders coalesce together. And because there are a lot of comorbidity or major depressive disorders with other disorders too. And when we think about eliminating or reduce the symptoms as a clinical objective, when we think about curing something, we're thinking about actually eliminating all the symptoms. But in fact, when we develop treatment and using clinical trial to assess them, a significant reduction of some of the symptoms is sufficient to define as efficacy. So you can have a drug that works, but not necessarily complete cure. And that is always been somewhat a complex situation that we need to be aware of. And perhaps that is a representation that as a condition, it involves many molecular mechanisms, addressing some of which improve and reduce symptoms. But when, at which point is it ever going to be totally symptom-free? That is not a trivial question. With this picture in mind, so what do we do? The last 50 years, we've been studying the biology and chemistry of symptoms, and the outcome would be that they are primarily all to do with monoamines as a chemical signature. When we say monoamine, we talk about noradrenaline, which using drugs to improve or reduce noradrenaline release, changing the metabolic profile, we found that it's associated with these behavioral outcomes versus serotonin, which have overlapping but also distinct psychological outcome. And last but not least, dopamine. Those are the three monoamines, which is the three pillars of conventional neurochemistry. And that is where we came from in terms of conventional treatments. And it's another picture. I apologize for the slight murkiness, but it is basically another way to show that with the presynaptic terminal on the left and postsynaptic terminal on the right, the number of drug targets we've been used for treating depressions are serotonin. On the presynaptic, they are the transporter for serotonin, noradrenaline, and dopamine. On the postsynaptic side, you have a multitude of monoamine receptor targets, adrenergic, serotonergic. There's 14 different serotonin receptor subtypes. So many drugs been developed, but all of them under the umbrella of monoamines. And they all have limitations. And frankly, coming from this 50 years of experience, what are the challenges for drug discovery? In this review article, is a bit dated now, but most of the elements still remain true. This is something that I was very interested and remain interested in when I was young. And that would be the challenge is that none of the animal model predict the disease well. Frankly, there isn't such a thing as animal model of depression. You might develop animal model of depressive symptoms, but there is no real animal model of depression. It's not like, if you infiltrate an animal with a bacteria, a strain, and they will develop bacterial infection of one type. That is not the case in psychiatry, and definitely not the case in depression. There's no line by site connection between a single target, none of those receptor target in animal, and the drug action in patient. SSRI, selective serotonin reuptake system, is used to manipulate serotonin, but it's not clear whether it's activation or blocking one target that give rise to that action. And when you have the drug acting on a given target, let's say blocking the serotonin transporter, that is very acute. You can measure the blockade, but in terms of relieving and depression, it typically takes 3 to 4 weeks for the SSRI to kick in. So there's a dissociation between acute pharmacology and clinical outcome eventually. And there are different type of patient population with different type of comorbidity and lung, and there's no unifying theory of what goes wrong. And in fact, no, patient invariably, we always say that in neuroscience research in pharmacology, we study the population, but in fact, when it comes to treatment of patient, it has always been individualized. And there lies, when we think about personalized medicine, we never can forget the fact that each human being exhibit different combinations of disorders and with comorbidity. And the difficulty of modeling, the difficulty of finding new target becomes so severe that for the last 15 years, most big pharmaceutical companies decide not to invest in psychiatric drug discovery. It's slowly coming back, especially with new biology. But until 5 years ago, every single major pharmaceutical company have decided not to spend money on doing psychiatric research. And they all switch over to rare diseases. And most of those rare diseases are genetic based, whereby the deficit of one pathway, one target, one protein, and you can do gene editing, like spinal muscular atrophy, which is a fabulous case in point about treatment of baby with weak muscle, otherwise will die because of genetic disorder. So drug discovery come very far. I can understand why companies spend more money on rare disease, whereby they can do something about it. But on the other hand, I want to encourage this population not to give up and thinking about a mental disorder, because it is the scale that impacts society and human race is tremendous. This is a summary of where we came from. When drugs for antidepressant approved, they approved as either first line, which means that the patient with major depressive disorder can be treated alone with this agent. They are including Prozac, a lot of these are generic names, but most of them is not unfamiliar. Sertraline, citalopram, fluoxetine, which is Prozac, agomelatine, which is melatonin, versus second line treatment, and then third line treatment. All of these are monoamine drugs, and all of them have incomplete remission. In fact, with all this existing first-line therapy, it can only achieve remission, and that is eventually patient with symptoms all disappeared, and they stay healthy and can come off the drug. It only occurred in up to 30 to 35% of the patient. In fact, 60 to 65 do not achieve remission. They have either partial, or in fact, they have what you call treatment-resistant depression. And that is a very, very dire problem. Other things, none of the existing treatment can address the cognitive deficit. All of them have delay in action. As I mentioned, require 3 to 4 weeks for the drug to kick in. And so what other non-monoamine mechanism should we be thinking about? There's a lot in the scheme of the world. I'm sure there are a lot, but what are they? Do they involve neuronal growth or epigenetics? Because more and more studying epigenetic, manipulating the chromatin remodeling, the expansion and the gene expression have demonstrated exquisite behavior like starvation, like aggression can be transmitted through the genome down to the son and the grandson. So there's another level of epigenetic organization and potentially manipulation that we need to think of. So this is why, in addition to neurochemistry, what other area to look at? We should be looking at genetics, looking at, can we model the behavior? And how about stress is a big one, and we'll spend more time on this. And how about measuring resilience as a preventative training measure? Do we look at circuits with such superb advance in imaging technology in real time? No. And what are the cell biology marker that we should be looking at? In a brief summary is that in the remaining of the slide, we'll be focusing on non-monoamine mechanisms and focus on what are the avenues and opportunity for doing translational neuroscience. We're talking about non-monoamine target like the excitatory and inhibitory neurotransmitter, glutamate and GABA, and other ion channels. We're talking about things that coming in vogue. It started about 10 years ago when more and more attention being paid to psychoimmunology and the role of the interconnecting tools of inflammation. And in addition, more new finding about neurovascular dimension. So let's proceed forward in the remaining of my talk. Where does the excitatory, the glutamate receptor science come from? Like in a lot of science, when the world was young, I had the good fortune to work on a brand new, exquisitely selective glutamate NMDA antagonist called MK801. In those days, in the mid-80s, we desperately looking for a way to treat stroke, excitotoxicity. And we came across a anticonvulsant. It makes sense because if you can block excitation transmission in the brain, perhaps it would be a good anti-epileptic. But in the process of studying this molecule, in fact, it was my first project as a member of staff at the Merck Neuroscience Research Center. And I managed to radio label it to identify a target. And I found that, in fact, this target is acted by a multitude of previously underappreciated NMDA antagonists, one of which is ketamine. So the question is, in addition to produce anti-epileptic action, what else can it do? And you will find a lot of drugs can do a lot of things. It's really a balance of efficacy versus side effect profile. One of the action, as we found, is some of you might heard of ketamine or little K as a drug of abuse. When one want to have a bit of too much fun in a nightclub, sometimes I ended up be the recipient of little K. I'm not professing a drug taking, even though I'm a pharmacologist. But in the course of studying, particularly this study at Yale, they found that in addition to anti-convulsive effect, ketamine, if given to treatment-resistant patient at the dose of 0.5 milligram per kilogram by injection, I in fact show a remarkable onset of antidepressant action on these otherwise very ill treatment-resistant patients. Treatment-resistant depression are people, nothing works. None of the conventional antidepressant work. And in fact, they will have to ECT, electroconvulsive therapy. And these are the difficult patients, but yet within 24 hours, IV administration of ketamine demonstrate repeated efficacy. And follow on, they do many more trials and understanding that this is glutamate NMDA antagonist that works repeatedly, first in IV administration of ketamine, but then subsequently, they also demonstrated that the racemic enantiomer S-citalopram, S-ketamine, actually works even better. And when they utilize a nasal formulation, they actually demonstrate very clear and strong efficacy. So this is the first time whereby a nasal spray medication have been demonstrated to work in the psychiatric disorder. Is really quite remarkable, frankly. And this is why I cheekily call this, "Can I smell a cure?" And this is the example of the type of clinical trial data we observe. A lot of the trial, especially treatment-resistant patients, they have to have an oral antidepressant already on board because they don't want to withdraw in case the patient develops suicide. So testing is in the presence of like a sertraline or citalopram or venlafaxine. When you add nasal S-ketamine on top, do you produce an efficacy? And the answer is whether using a 56 or an 84 milligram dose in an inhaler, they can significantly demonstrate continued improvement of the MADRS scale of depression. So as you can see, in each and every time point, first time point being 1 day after inhalation, but it continue over and once dose, it continue to improve. So it doesn't go away either. So this is the type of phase 3 clinical data to demonstrate that transnasal intranasal S-ketamine can work in treatment-resistant patients when add on top of a conventional oral antidepressant. This line of study continue to be exploited. Now we have thousands and thousands of patients receiving this treatment. And in fact, as we look into it, when you target the glutamate receptor system, there are multitude of glutamate receptors beyond NMDA. And in fact, there are data showing that other glutamate targets can also be manipulated to address antidepressant action. The other example of non-monoamine target that I'd like to draw your attention to, just so that you have a broad picture of emerging options, and that is for the first time in years, we now have an approved treatment for postpartum depression. Women given birth, over 20% of them will develop depressive symptoms, and it can be very debilitating, giving rise to inability to maintain childcare, to severe depression. And what this company has found that a neurosteroid molecule is a allopregnanolone analog was able to, by infusion for 60 hours, can steadily and immediately reduce and relieve depressed symptoms. And in each of the time point thereafter, up to 30 days, there's a separation between the placebo population and that one receives 60 hours infusion of this neurosteroid. That it works on the GABA receptor target. So again, no, for 30 years, we have not any new and truly non-monoamine drugs. And the last 3 years, we have 2 new approvals. So things are really looking up. But what about going towards in the future? We did some, even 10 years ago, we've been asking more and more in biological psychiatry research, how do we model treatment-resistant depression? Are there biologically or neurochemically something more severe about the brain and the system of the host? Because we have been modeling animal model based on anxiety open field study. We can model about isolation, loss of interest by sucrose drinking, sleep problem, fatigue, so on. But one of the things that we've increasingly becomes clear over the last 20 years is that chronic stress is a major risk factor of depression in humans. And this is done by the pioneering work of Bruce McEwen at Rockefeller University in New York and Robert Sapolsky when he was a young postdoc, but currently in Stanford. And this set of literature about chronic stress, in a way, is part of that nature versus nurture. Environmental influence is incredibly important, is sustaining neurobiological changes. And we have when I was working at AstraZeneca, I had the good fortune to do a collaboration with Eric Nestler and his team. And we want to identify novel target. And particularly we use a social defeat model of chronic stress. In a way, it is a model also of psychological trauma, which means that when we put a box of a CD1 big bruiser of a male mouse in a box and put in a C57 black 6 mice, and it's an aggressor situation. And for the first encounter, they are allowed to make contact, and the little mouse was encountering aggression for 5 to 10 minutes. The subsequent 10 days, the mouse will be put in the box, except now he will no longer get to be touched or beaten up by the aggressor mouse, but he can see and feel and continue to experience the stress and the danger and the remembrance that of the aggression. After these 10 days, a constellation of symptoms occur, including loss of pleasure, anhedonia, both for sucrose and sex, have anxiety symptoms, hyperactive HPA axis, develop metabolic symptoms, and disruption circadian rhythm, and profound social avoidance. And to cut long story short, if they measure the social avoidance within 100 C57 black 6 mouse, only about 30 to 40% of them will develop social avoidance. Why? The mouse that have not been exposed to aggressor is measured with normal avoidance behavior, versus there's a group of resilient animal that are also so apparently normal. The terminology, we call this population defeated versus the other group resilient. And doing the biology in the defeat and versus resilient represent the framework for next 10 years of research. One of the work that we collaborate with is actually look at the role of peripheral immune system in promoting. To cut a long story short, I would really encourage you read this paper by Georgia Holders at PNAS 2014, and that is the neurochemical and immune signature of the resilient is the normal level of multitude of immune markers versus the susceptible, whereby they demonstrate elevation of IL-6 as a major factor. And we can do genetic manipulation, whereby if the animal who are susceptible, if we inject them with IL-6 cytokine monoclonal antibody, you can transform the behavior of this animal from susceptible to resilient. And on resilient animal, if you genetic manipulation to get the bone marrow to release excessive amount of IL-6, we can turn the resilient animal into susceptible animal. These are the sort of data that inform us about the relevance and the importance of the intermediate messenger between stress on the one hand and the peripheral immune system, and then the ultimate presentation of depressed symptoms and the other. But so how could peripheral immune system influence brain function and behavior? This is where psychoimmunology, the field gradually come in In fact, when we think about psychological stress and impacting on immune system, is more than just psychiatric disorder. It's very disease permissive in terms of increasing chronic inflammatory disease like irritable bowel syndrome, including cancer, cardiovascular disease, acute and chronic viral infection. So this is very insidious. Thereafter, there are multitude of papers talking about how linking social stress to even neurovascular pathology, and that is the increase in abnormal permeability of the blood-brain barrier. And you can actually do imaging of the markers of defective blood-brain barrier and regional specifically how it can occur in nucleus accumbens and other relevant area. I talk about how the relevance of stress and the translational value. I will end by talking about when we think about translational neuroscience, what can we study from human? And what do we understand about the causal relationship of depression? And that is, we know that adverse childhood experience, ACE, like physical and sexual abuse, neglect, maternal experience, community experience, like war and refugee, these are all major toxic stress that can impact the brain. And measurements of blood-brain barrier, recruitment of astrocytes and microglia and astroglia, these are all potential markers we should be aware of. Inflammation in peripheral and neural inflammation in the central. Relating to cortisol and genetic markers is the way to go forward. I'm trying to wrap this up, again, showing that in the CDC did a study using the chart of 20,000 patients from beginning of life. They can measure their ACE in terms of childhood experience, and what they found that there's a greater increase with more exposure to trauma, the more in terms of chronic depression, prescription of antidepressant, suicide attempt, impairing of work function, and all the way towards obesity and diabetic metabolic situation. So social stress and toxic stress have a major impact, and it crosses all cultures of ethnicity. Who would have thought that a stress that impact on psychiatric condition can also precipitate down the line to obesity and diabetes. This is just basically a summarize how depression, stress impact through inflammatory cytokine through the immune system can be very relevant when we think about if we were to address, detect, and address by preventing depression, should we be thinking about these other measures and substrate? And in the future, no, we are more than a mouse. Can there be biomarker of stress and mood-related disorder? When we think about novel antidepressant, we're already seeing some. Perhaps a new molecule could be one that protect the blood-brain barrier from the leakiness, so that the external insult of the immune system cannot be spread into the central nervous system. And what's the role of reducing appropriate and contextual inflammation? And we might be using biomarker for imaging blood-brain barrier as a way to diagnose, like measuring heart rate. Now I conclude by saying that my colleague and I did a review article on last year in terms of what other things we need to think about when we want to re-engage psychiatric drug discovery to strengthen confidence in translational neuroscience. I don't have the time to go to it, but I do want to just draw your attention to it when you follow up. Last but not least, and when we talk about non-monoamine target, beyond neural inflammation and immunomodulation as targets like IL-6, IL-17A, and TNF-alpha. There are also molecules that address the bioenergetics, even neurogenesis, whereby there are current and preliminary clinical trials showing that in treatment-resistant depression, as an add-on to existing oral conventional medication, some of these molecules starting to show efficacy. So when we talk about emerging options, these are some of the emerging options that we should be keeping an eye on as they become more and more available with new clinical trial encouraging data. So I feel this is very, very encouraging. And I will wrap up by saying that I have been talking about mental health burden and walk you through where we came from and where we are going. And I hope that you get a sense that there are very real optimism and opportunity going forward. And in all cases, to do with appropriate modeling of systems beyond just the brain, but to other peripheral systems, a multidisciplinary approach. And I'll end by saying that I once upon a time was like you. I was a student, graduate student, and please excuse, can you see the fashion in those days? This was 1988, excuse me, 1978. I was at I did my PhD at National Institute for Medical Research, which is now called Francis Crick Institute. And it was the best time of my life. For 3.5 years, I spent all the time thinking about how can I fit my squash games around my experiments. The thing about surviving the PhD education is not only about studying and learning, and looking back, it's about developing resilience, cultivating friendship and relationship. All these people have become eminent scientists in their own field, members of National Academy of Science. And I was there 40 years ago. And in that case, I would stop and open this up for question and hope that's something that you can take away from this talk. A lot of you are still on mute. So if somebody have some question, I will try to answer them.
So I guess we have some questions in the chat. I'll read out the first one. So the first one is, this falls a bit outside of neuroscience, but is there any insight on how antipsychotic use among the prison population is for treating relevant mental disorders, as opposed to a means for controlling problematic individuals? Okay,
that is a very good question. And in fact, I don't think it falls outside neuroscience. I think really understand the neurobiology. Neuroscience is using multitude of technique and methodology to understand neurofunctioning. So nothing is really outside neuroscience. In fact, I would go as well as saying neuroscience is humanity. I would go as far as saying that. And in the question, that is a very insightful question, because how you draw the line between using antipsychotic to control their behavior versus addressing their symptoms. And in fact, it's a bit of both. It really depends on what drug you use. For those who remember antipsychotic 30 years ago in the era of One Flew Over the Cuckoo's Nest, or some who remember that Jack Nicholson movie, they were using haloperidol, which is a major tranquilizer as an antipsychotic. That is a pure and powerful dopamine blocker, pure and simple. And that's a major tranquilizer. And they were used really to pacify the individual so that they don't thrash about, they don't become a menace to themselves and the environment. Since then, we have second generation of antipsychotic. Some of them are better than others. And like clozapine, one seems to be able to reduce the psychotic, the delusional symptoms, the recalcitrant, violent behavior without knocking them out. So it really depending on what drugs they choose to use. and what drugs the prison doctor and the system prescribe. The aggressive acute management, they still need to use intramuscular injection to reduce their severity. But on maintaining basis, there are multitude of drugs which are antipsychotic that are used, like risperidone, so on and so forth, that actually can reduce the psychotic violent behavior without knocking them out and tranquilizing them. And that also is the case in the general population. The only difference is that general population patients have not developed manifestation that get them into trouble. Next question. You're welcome.
I think so. The next question is from Thomas Riley, and it's quite a long thing. So would you like to unmute and ask the question, Thomas?
Sure. Can you hear me okay?
I can hear you very well.
I've actually got my Aberdeen jumper on because I went to Aberdeen as an undergraduate as well. So
oh, there you go.
So I'm a psychiatrist. I'm now based in King's College, London, and I'm really interested in the effect of sex hormones and psychosis in particular. And I was really fascinated to hear you talk about brexanolone. I was wondering if you had any thoughts about why allopreganolone and brexanolone maybe aren't as hyped as ketamine. And certainly I don't think that it has been approved for use in the UK or the EU. It seems to me like it could be potentially promising in a number of different psychiatric conditions. And I'm aware that obviously the fact you have to give it as an infusion isn't ideal and it's very costly at the moment, but I understand other oral preparations are under development. So I just wondered if you had any thoughts about why maybe it's not, people aren't as enthusiastic about brexanolone.
Okay, well, you know, that's actually 4 questions, not 1 question. No. Thank you for showing an interest. I mean, those are very relevant questions. But the answer to questions are not just biology, but also approval process, reimbursement process, and clinical practice. No, the fact that ketamine is slightly ahead, not a lot, but the science behind went through, now this is the work of John Crystal's people at Yale. Then a whole bunch of them moved down to Mount Sinai, and they are the one who push hard. And if for patent approval, they, instead of using ketamine, which have 0 proprietary benefit, to S-ketamine and nasal. This is how they get a patent approved. And this inform you about, it's not biology, it's tradecraft in that case. But the point is that repeatedly, the ketamine NMDA effect seems to be very robust, which is interesting. And it also block, so there are Travati, whole bunch of psychiatrists in the field really spend years of work on. So there's a lot, for me, a lot more background on ketamine work and the clinical credibility there. And also it's a drug that's relatively cheap to manufacture. The nasal, and they have to be delivered in the doctor's office, is still somewhat an impediment. And there lies the problem. That's the major problem, is when US approval of a drug beyond biology, there's something also other factors involved. There's not a synchronized process between EC, UK, and US. We've seen it on most drugs. But for the postmenstrual depression, postpartum depression, it is very cumbersome, as you know, as a psychiatrist, to give a patient stay infused for 60 hours. So the comparison, and how much the doctor or the NHS are about to allow to charge and the cost involved in terms of clinical management of a patient in a clinic for 60 hours, staying overnight. Those are very complicated and cost issues, which could get into the differentiation between, and also those are two very different depressive population. One is treatment-resistant depression, which are incredibly severe and dire. Those people have to resort to ECT and they're still resistant. Though they really at the last stage. And so there's a lot of motivation to try intranasal versus the question that you were almost about to ask, but not yet, is would allopregnanolone, brexanolone, and zuranolone is the oral available molecule after brexanolone. And in fact, the clinical trial data from zuranolone is coming out now and showing very good effect in MDD, not just, so that's the way you look forward to, is not to wait and to be critical about brexanolone, but wait for the oral formulation to come. And hopefully the NHS, if the clinical data is robust enough, the NHS will jump on that and make it available, because for me, that will be the coup that we hope for. Does that answer your question, Thomas?
Yeah, very much so. I will have a little patience then and wait for more results to come out.
And feel free. I mean, I'm retired, I'm teaching, but if ever you are interested in having conversation and bounce off idea, I'm always very, very much enjoy talking to clinicians.
Thank you, that's very kind.
And Rice will have my contact email detail.
Great, thank you.
Okay. Any other questions?
We have many more questions in the chat, actually. The next one is from Thomas, so if you'd like to unmute.
Sure, thanks for taking my question. I'm a PhD student. I've worked in pharma before, and I was just sort of wondering what the career outlook for CNS drug development is like, because it's been pretty grim for neurodegenerative disease, in particular for Alzheimer's drugs. And if you could offer some current perspective on that.
Yes, I definitely can, because amongst the places that I work, I happen to also work for Biogen, which is, of course, caught the headline because they have the monoclonal antibody against the A-beta peptide, which, surprise to everybody, got approved, even though the data is very slim and selective. A broader question I ask you that you ask is that when you are well trained, when your personality and your interest and you're able to convey your passion, there's always opportunity for scientists like yourself. Getting the training is really the foundation. Teaching you how to answer really good questions, how to address them, and how to go across discipline to build up a big picture of what are the points that have been missing and where you can make contribution. Industry desperately need young scientists with minds like that. And in my career of 33 years, I've hired over 100 PhDs, and I always look for young scientists, neuroscientists, who are able to not so fixated on the system they study, but rather what question they have asked and what's the implication and how you as an individual can offer that organization. The way you think, the way you're able to work as a team, the way that you can collaborate, and the way that you publish. All of these are factors that company will be looking at. Now, the applying for us as a scientist job, the basic requirement is a PhD or DPhil. That's just to get your foot in the door. Whether you can enter the door into that world is depends on how you, pardon the word, market yourself, but not like stepping on a soapbox, rather than being really able to zoom in. Why do you think the latest science is so necessary? to break the barrier in drug discovery, whether it's neurodevelopmental, neurological, or psychiatric. And it really is, running a group, running a team is how do you utilize your scientific training to distill it down. And often the case, building models that have translational value so that what you measure in your models have a better chance to be tracked in human. And therefore, that's the problem with psychiatric drug discovery 30 years ago, is that all the animal model we use, we fool ourselves as being modeled with some face validity, not a lot of construct validity, and no predictive validity. And so that if a drug works in the animal, put it into the patient. If it doesn't work, we do not know where to go. This is why translational measurements is so important. You want to measure some mechanism, some biomarkers, some pathway, some imaging tool, whereby you can track whether the drug is hitting that target at that location. And if it doesn't work, it's not because it's not getting to the target in question. I mean, I can go on and on, but I won't, because but I hope I give you some thoughts behind how you can leverage your training and education to drive forward. And I will encourage all neuroscience to think about how they can utilize their neuroscience skill to impact the world and the world community. Not that publishing and becoming an academic is not exciting, but for me, I just happen to be very passionate about turning my science to impact and reduce people's suffering.
The next question is from Mark. So if you'd like to unmute and ask your question.
Hello, Mark.
Hi, thanks for the great talk. I just had a question in terms of preclinical models for complex psychiatric disorders. What do you think of using organoids or assembloids for understanding disease mechanism and potentially looking for drug interactions to help with preclinical modeling for psychiatric disorders?
Yes, thank you for asking that question, Mark. As we all agree, animal models, depending on the complexity, each have this limitation. And until recently, I mean, more organized, like one can think about how about the a model of an organ is, for example, the blood-brain barrier as an organ system, with the endothelial, with all the elastin or claddin, all those markers that constitute and manage the permeability of the blood-brain barrier. So in that sense, perhaps we now, with the work of Caroline Maynard that I mentioned towards the end of the talk, we can begin to use organoid. If you have zoomed in on the fact that abnormal manipulation, or rather abnormality of blood-brain barrier and permeability is a clinically relevant. Can you, one, image it, and two, develop molecule can tighten the blood-brain barrier, for example, to render the human more resilient to stress-induced peripheral immune onslaught. Now, that's quite a mouthful, but I hope you understand what I'm trying to say. But in that case, it has to have the right relevance and the right context, and not just pick any organoid. And of course, if you're trying to answer animal model of psychiatric condition that are involving complex behavior and circuit, then organoid system might not have the enough complexity. I mean, people have been thinking about iPS cells that get rederived into neuronal cell type. Some work's been done in the fibroblast skin cells of schizophrenics to see whether they have certain abnormality they can carry on. It's going on all the time. for me, the struggle and the caution would be depending on type of condition you seek to model. Some of them, the organoid system might be sufficient, but other one, they might have its limitation. And so we come down to, it really depends on what you are modeling and how close it is to the sequela that you seek to manage. Have I answered your question, Mark?
Yes, thank you.
You're welcome.
So our next question is from Sarah, if you'd like to unmute. Yeah, I'll read it for you. Okay, so the question is, would you please repeat what are the rates of effectiveness in the currently available antidepressants? How many people respond well in terms of going to remission? And what monoamine-based drug has currently the highest rate? This helps in comparing the effectiveness of ketamine therapy. Thank you.
Okay. The reason why we always say conventional antidepressant of the monoamine type in complete efficacy is that only 30 to 35% of the people when take this monoamine drugs achieve remission. The other 60, they might start off having some efficacy, but then they taper away. So it doesn't mean that they are not deriving some benefit, but they do not stay symptom-free. Within the first line monoamine antidepressant, we came from, the first one is Prozac, selective serotonin. Then you had serotonin and noradrenaline combination, and you have dopamine serotonin combination. Example like duloxetine. It comes down to what the psychiatrist and what the GP or smart GP would do is to look at the constellation of symptoms the patient present to him or her. If it is symptom of, they all have depressive and anhedonic symptom, hence the sign and agreed to be MDD, major depressive disorder. But on top, if there's a lot of sleepiness and overeating, that type of symptom and inability concentration, perhaps a serotonin plus a noradrenergic would be helpful. This is why the duloxetine from Lilly have been quite good. On the other side, there are other people who said that that Lundbeck, who use escitalopram, is just as good as Prozac, but has less side effect. But the other thing that is GP don't seem to keep up the literature, and perhaps partially because of pricing, is that what about Cognition? Lundbeck has a newer drug, which I think might or may not be approved in the UK. It's called Trantilex. It is a selective serotonin reuptake inhibitor with combination being able to act on serotonin 6 and serotonin 7 receptor, which seem to address the cognition more than Prozac, sertraline, and other drugs. And so if why the side effect profile remain quite benign. So if I were a GP and if I'm presenting a patient, either elderly or young but with cognitive problem, perhaps Trantilex is the way worth trying. First criteria is always do not do any harm. Try not to bring on medication that create a lot of unmanageable side effect. But all being equal, there are some basis of pharmacological selection to adjust the characteristic of the conventional antipsychotic to the constellation of symptoms that one tries to manipulate and reduce. Does that answer your question, Sarah? I hope it does.
She said, thank you. Yeah.
You're welcome.
Okay, our last question is from Nushin, if you'd like to unmute. If not, I can read it out loud. Okay, yeah, I'll read it. So recently there are some papers on the success stories of psychedelic treatments to TRD, psilocybin. Could it be a competitor for S-ketamine?
Yes, definitely. Both of them have stigma. Ketamine have a bad history of drug of abuse. So no, doctor will have to be very careful. Although transnasal being treated in the clinic can overcome some of the addictive potential, and frankly, the doses that were used will create a buzz, but without being not like jumping up and down in Ibiza in a nightclub type of scenario, which is one you want to get away from. Psilocybin is got there are more and more clinical trials showing that it work in treatment-resistant depression. I started to see some pretty good clinical data as add-on. So I don't know whether at some point they will collect enough of good quality data to justify approval. But I think the hesitancy might share somewhat with ketamine. Is at which point does it achieve the respectability such that doctors and the world community feel that this is truly medication and not as an oblique way of achieving highs. There's always that kind of a balance of you never have to worry about with anti-cancer drugs. Nobody in their right mind will abuse anti-cancer drugs, and chemotherapy. But anti-anxiety drugs, anything that make you feel better, make you relax, alter your state of perception, can be desirable. There's nothing new. I mean, human beings been utilizing that for thousands of years. So I think that will come. I hope psilocybin will show the efficacy side effect ratio that render it is acceptable with robust efficacy. And that is a combination of serotonin receptor involving 5-HT1 and 5-HT2. That is, and some adrenergic component. And it's still a monoamine drug, but I'm all for it if it offers new dimensions in treatment-resistant depression, which is a very debilitating, highly dangerous condition.
Thank you. So in the chat, Sarah has one more question. So yeah, if you'd like to unmute now.
Thank you very much. In continuation of my last last question, you explained how each type of the medication addresses specific problems or issues with that people can have. With ketamine, it's a dissociative
anesthetic.
Yeah, anesthetic. So I'm curious. I know that it may not be very scientific, but since dissociation is very common in many of the depressive people, isn't it counterintuitive to give them? How does ketamine is helpful, or for which type of people ketamine will be more helpful? If thank you.
Well, you can start by asking that, not so much personal perception, but rather let the data speak for itself. As scientists, we always go there first. And if you look at the clinical trial population, the treatment-resistant population, look at the age range, look at the sex distribution. The clinical trial typically trying to balance male-female, age between 20 to 60, so on and so forth. I would say that ketamine probably is working when we say that it's a dissociative anesthetic. In fact, as you know, all trauma surgeons, whether it is in the ambulance or in the air ambulance, when they go to trauma situation, first thing they do when they see that patient collapse with severe trauma, bone broken, dislocation, open wounds, bullet wounds, first thing they do, they IV push a dose of ketamine in them. And it really improved the survivability, and they don't remember that trauma so much afterwards. So that's at the high dose is used to create a dissociation.
Exactly. So for PTSD, for example, I understand, you know, it's intuitive to use this for PTSD therapy, combined, you know, ketamine for PTSD, but for depression, for major depressive disorder.
The dose and the blood level is different. It's not as high. So that's another thing. Using a drug, different dose can have very different profile and the system impact. And the extensive study by Yale group, by the Mount Sinai group in New York, and basically they've done a lot of work showing that at the 54 to 86 milligram translational dose, it is achieved that give the brain a buzz. Some people can say that no, they can feel a slight stimulation, but not enough to get high. But at that dosage, the NMDA antagonist somehow is enough to impinge on the circuitry could be break up that constant, what you call it in treatment-resistant depression, that rumination, that prefrontal cortex loop that go round and round. Sometimes it's disrupted by Helen Mayberg by using brain implant to fire at that region to break up that circuit. So depressive symptom is very complex, involving multiple systems. So the fact that at high dose it can create anesthetic action doesn't mean that anesthetic dose require that. It's a way. The reason why we do a lot of clinical trial is get it to the range whereby we can have the desired efficacy without the stimulation or undesirable profile. And as ketamine as an intranasal is right at that point whereby it's trying to it's a chicken on the egg first. If people worry about it, they don't want to try it, then you never get enough clinical experience. But if you get enough experience, then the doctor will feel comfortable that at this dosage range, under this condition, I can give patient a chance for treatment-resistant depression. And that's what we need to see. And typical once drug approved in 2018, it probably takes like up to 5 years to get to some point of comfort whereby other psychiatrists feel comfortable using it.
Yeah, thank you. Yeah,
you're very welcome.
Thanks. The dosage.
All right, thank you so much, Dr. Wong, for a wonderful talk. And yeah, it was quite insightful, and I'm sure everyone came out of this with a lot of knowledge. And yeah, thank you. And it would be wonderful to have you come to Oxford in person to give a talk. Hopefully we can arrange that next year.
Sounds good.
Yeah, and thank you all for attending our talk. We have many more talks coming up throughout the term, so do check out our term card. So yeah, thank you.
Okay, thank you.